Okay, guys, so electrolytes is the last topic for our prelims. I checked the syllabus. Okay, we have a lot of topics to cover for your CC2 because this is already the combination of the CC2 and the CC3. So in the old curriculum, dapat 2 sem to kaso ginawa siyang 1 sem. That's why the topics, there are a lot of topic to cover for each term. Okay? So electrolytes, these are ions capable of carrying an electric charge. So there are two types, anions and cations. So if that is an ion, it carries a negative charge and moves towards the anode. Pag cation naman, it carries a positive charge and moves toward the cathode. So electrolytes are an essential component in many processes. Okay, so they are involved in volume and osmotic regulation, just like for sodium, chloride, and potassium. Myocardial rhythm and contractility for potassium, magnesium, and calcium. They act as cofactors in enzyme activation. So, a notable electrolyte for this one, cofactor, is the magnesium, which serves as a cofactor for 300 enzymes. If you remember, approximately 300 enzymes. Calcium and even zinc, as well as in the blood coagulation for calcium and magnesium. So later on in your hematology 2, uh, you will have a discussion how important calcium is for blood coagulation. Okay, so wait, I will pause this because of the background noise. Okay, so we proceed with the next slide. So water. So let me check the sound. Okay, so it's working well. So water, that is 40 to 75% of human body weight, is made up of water. However, this one, it declines with age and obesity and women. Okay, so water has in a woman's body, it has a lesser water content as compared to men because of the higher fat content. So kapag mas mataba ka pala, mas konti yung water content mo. Okay? So water is solvent for all processes in human body because it transports nutrient to cells, determines cell volume by its transport into and out of cell, remove waste through urine, acts as body coolant by way of sweating. So, what is found inside the cell, that is two-thirds. Okay? As compared sa compartment, ibig sabihin nun, mas maraming fluid pala ang nasa loob ng cell. Okay? So, anong mangyayari kapag yung cells nasira? That will lead to dilution. Okay? So, tataas yung volume ng water sa extracellular compartment. Kagaya sa blood, kapag nagkaroon ng intravascular hemolysis, ano mangyayari? Tataas yung plasma. Okay? Tataas yung water part ng blood because of the dilution that happened. Kasi mas mataas yung water level sa loob ng cell as compared sa labas. Okay? So normal plasma is about 93% of water. So the concentrations of ions within cells and in plasma are maintained both by energy-consuming active transport processes and by diffusion or the passive transport processes. So you already know the difference between the active and passive. Okay? So the main difference involves the use of ATP, right? So sa active transport, it uses ATP. Okay? So kagaya na lang ng sa sodium. Okay? So when sodium is transported from outside to the inside of the cell, or vice versa, so sodium palabas, anong nangyayari? It needs an energy. Okay? So, gumagamit siya ng ion pumps which uses also energy. So, on the other hand, sa diffusion naman, passive movement of ions through a membrane. So, it does not need ATP. So, that is in diffusion. So, osmolality, that is the physical property of a solution based on concentration of solutes in millimoles per kilogram of solvent. Therefore, it measures the number of solute or the concentration of solute relative to the volume. Okay, yun yung mini-measure niya. Yung number ng solute dun sa relative sa volume na present. Okay? So, the osmolality is related to changes in properties of solution relative to pure water. So, what are the clinical significance of osmolality? Okay, si osmolality is the parameter to which hypothalamus responds. Okay, so the hypothalamus responds depending on the osmolality of our body. Okay, so especially on the osmolality of the blood. So, regulation of osmolality affects plasma sodium concentration. Kasi majority ng solute that contributes to osmolality is sodium. Siya yung main contributor. Okay? So, sa mga electrolytes, okay? Sa mga electrolytes, si sodium ang main contributor. Regulation of sodium and water controls the blood volume. Okay? So, regulation of sodium and water controls the blood volume in our body. Determination of osmolality that can be measured using serum or pwede rin naman sa urine. So, both the sensation of thirst and arginine vasopressin hormone, also known as the antidiuretic hormone. So, this is the former name, antidiuretic hormone. Okay? So, or the AVP. So, both, take note of this one, both the sensation of thirst and the arginine, okay, or the arginine vasopressin hormone, are stimulated by the hypothalamus in response to increased osmolality of the blood. So, kapag nagde-detect ni hypothalamus na, okay, mataas yung concentration ng solute sa plasma mo, anong mangyayari? Magre-release yung hypothalamus ng sensation of thirst. Bakit magkakaroon ng increased sensation of thirst? Para kailangan mong mag-intake ng fluid. Pag nag-intake ka ng fluid, anong mangyayari sa mataas na osmolality? It will be diluted. So, bababa. Yun yung magiging effect niya. Okay? Why is it that AVP secretion is also stimulated kapag mataas ang osmolality ng blood? Okay? So that more water is conserved sa kidneys. So, kapag more water is conserved sa kidney, anong mangyayari sa blood volume? Tataas. So, kapag tumaas yung blood volume, bababa yung osmolality. So, that is the body's compensatory mechanism when the body detects an increased osmolality. Nakukuha? So, kapag mataas ang solute concentration, anong ginagawa ng katawan? Okay, ina-increase niya yung sensation of thirst and the secretion of arginine vasopressin hormone to increase the blood volume to decrease this osmolality para mapababa niya yung mataas na osmolality level. Okay? So, the natural response to the thirst sensation is to consume more fluid. Yun nga, di ba? Iinom ka ng maraming fluid. Increasing water content of the ECF, extracellular fluid. Diluting the elevated solute levels and decreasing the osmolality of plasma. So, I already explained this kanina. Okay, I hope naintindihan niyo yung explanation ko doon. Thirst, therefore, is important in negating the fluid intake. Okay? So, if you feel thirsty, kapag nauuhaw kayo, that is an indication of the body na, okay, baka tumataas na yung osmolality mo. Okay, osmolality. That's why you need to take water. Kailangan mong uminom ng fluid because the body is detecting an abnormality in your system. Okay? So, the other means of controlling osmolality is by secretion of AVP. So, this hormone is secreted by the posterior pituitary gland and acts on cells of the collecting ducts sa kidneys. That is to increase water reabsorption. As water is conserved, osmolality decreases, turning off the AVP secretion. Okay? So, other way to decrease an osmolarity that is higher than normal is to secrete AVP. Okay? Para, yun nga, I already mentioned this one, to reabsorb, to increase the reabsorption of water, to increase the blood volume, and that is to decrease the high osmolality in the blood. So, osmolality, sodium is regulated by changes in water balance. Okay, so the osmolality is regulated by changes in water balance, but volume is regulated by changes in sodium balance. Okay, so si osmolality, nare-regulate yan by controlling water. Okay, on the other hand, to regulate water naman, to regulate the water or to have a balance of water in the body, sodium is regulated. Okay? So, we move with the different electrolytes. So, for the first part, I will discuss sodium and potassium muna. So, these are the most important Okay, kaya sobrang haba ng discussion. So for sodium and potassium, they will cover unto slide 75. Okay, and we only have we have 136 slides to discuss. Actually, na-shorten na to. Okay, so very shortened na to. If you look at the module that I gave you, sobrang haba niya. Okay, so sodium, the regulation of sodium balance in the body, okay, that is through intake of water in response to thirst, excretion of water, and blood volume status. So there are hormones that affect sodium level. Merong dalawa. Si aldosterone, the effect is to, sorry, for aldosterone, its effect is to increase, okay, increase sodium. Okay, how? Because it promotes absorption of sodium sa kidneys. Okay, so paano niya yun pinopromote? Pinopromote niya yung sodium retention. Okay, so it promotes sodium retention. However, at the expense of sodium retention, ano naman yung na-excrete? Kapag if there is retention of sodium, at the expense of this process, potassium is excreted. Okay? So, habang marami ang nare-retain na potassium, marami din yung na-excrete na potassium. Tama ba yung sinabi ko? Habang maraming sodium ang nag-i-stay sa katawan, maraming potassium yung umaalis. Okay, ganun siya. Another hormone affecting sodium level is the atrial natriuretic factor. It causes natriuresis. What do you mean by this one? It causes the excretion of urine, the excretion of sodium in the urine. So, ano yung effect niya? It decreases sodium through elimination. Okay, through elimination sa urine. I think na-edit ko to kanina eh. Okay, so those are the two hormones, aldosterone that increases sodium by promoting sodium retention, atrial natriuretic factor, it decreases sodium through elimination of sodium in the urine. So, take note of this one, guys. To maintain a normal plasma osmolality, that is 275 to 295 MOSM. Nakalimutan ko na to. I'm sorry. Tignan nyo na lang sa book. Okay? So, per kilogram of plasma water. Okay? Milliosmol. I think. Okay? But never mind. Check nyo na lang. So, to maintain a normal plasma osmolality, osmoreceptors in the hypothalamus respond quickly to small changes in osmolality. Okay? So, kapag nade-detect ng katawan na may change sa osmolality, magre-respond ngayon yung osmoreceptor that is found in the hypothalamus. Okay? That is to maintain a normal plasma osmolality. So, the AVP acts by increasing the reabsorption of water in the cortical and medullary collecting tubules. So, never mind for the parts. You will have an extensive discussion of this one in analysis of urine and other body fluids in clinical microscopy. Basta, it's important for you to know that AVP or antidiuretic hormone increases water retention. Okay? So, renal water regulation by AVP and thirst play important roles in regulating plasma osmolality. Okay? So, renal water excretion is more important in controlling excess water, whereas thirst is more important in preventing water deficit or dehydration. Ano ibig sabihin nito, guys? In Filipino, okay, kapag sobra yung water sa katawan, renal water excretion is the way to eliminate or to control if there is water overload. Okay? So, tatanggalin excretion of water through the kidney. Yun yung gagawin ng katawan pag sobra ang water sa katawan. Pero kapag kulang naman yung water sa katawan, kagaya ng dehydration, mauuhaw ka. Yun yung normal response ng body. Okay? Ganun siya kasimple. Water load. So, water overload. This should be water overload, guys. In water overload, anong nangyayari? Mababa ang plasma osmolarity. Bakit mababa ang plasma osmolarity sa water overload? Because of dilution. You have a lot of fluid inside your body. Okay? So, what will happen? Your blood is diluted. Therefore, your osmolality is also diluted. Therefore, their plasma osmolality is low. Ganon siya. Okay? So, kapag may water overload, what happens to AVP and thirst? That is suppressed. Okay? Nasa-suppress yung AVP secretion so that water is excreted. So, that is the compensatory mechanism. Yan yung gagawin ng katawan para makorek yung abnormal na mababang plasma osmolality. Okay? Iso-suppress niya ngayon yung pagkauhaw mo para hindi ka uminom ng uminom. Okay? Bakit hindi mo na kailangang uminom? Kasi sobra-sobra na yung water sa katawan mo. Okay? So, bakit masasuppress yung AVP? Para hindi na rin magkaroon ng water retention. Okay? Because you already have the water overload. So, the proper compensatory mechanism there is water excretion na. Kaya masasuppress tong dalawa. AVP and thirst are suppressed. In the absence of AVP, water is not reabsorbed. Okay? So, causing a large volume of dilute urine to be excreted. So, as much as 10 to 20 liters per day, depending on your fluid intake, well above any normal intake of water. Therefore, hypoosmolality and hyponatremia usually occur only in patients with impaired renal excretion of water. Okay? Ano ibig sabihin nito? So, it is not common. Hypoosmolality and hyponatremia does not happen to healthy individuals. Okay? Yung mga walang sakit sa kidneys. Okay? So, this one, hypoosmolality and hyponatremia usually happen to persons who have impaired renal excretion of water. Kahit inom ka ng tubig, anong gagawin ng katawan mo? It will just be eliminated sa urine. Okay? So, hindi magkakaroon ng low plasma osmolality. Kasi meron kang normal compensatory mechanism. Pero ang problema doon is kapag impaired ang iyong renal excretion. Okay? So, that will really lead to low plasma osmolality. Kasi wala ka na nung compensatory mechanism. Okay? Example ng water is not reabsorbed, causing a large volume of dilute urine. So, it occurs in polydipsia. What do you mean by polydipsia, guys? Okay? So, that is excessive thirst of water. So, you want to drink and drink water. Okay? So, that is one of the symptoms ng diabetes. The 3 P's, polyuria, polydipsia, and the polyphaga. Diba? Polydipsia, excessive intake of water. Polyuria, excessive urine volume or urination. And polyphaga, extreme or excessive sensation of hunger. Okay, gutom lagi. Water deficit. Okay, what happens in the osmolality of blood kapag mababa naman ang volume? Okay, low blood volume, low water volume in the body or in the blood vessels within the circulatory system. Okay, since concentrated siya, anong nangyayari sa hyperosmolarity? Okay, mataas. Anong nangyayari sa osmolarity? Mataas yung level, kaya nagkakaroon ng hyperosmolarity. So, as the deficit of water begins to increase, as the deficit of water begins, okay, to increase plasma osmolality, both AVP secretion and thirst are activated. Okay, bakit AVP and thirst are activated? So that you will intake more water. Okay, so that is the body's compensatory mechanism. Okay? So, kapag tumataas na yung osmolarity. Aside from that, AVP is secreted. Why? That is to retain more water in your body. Okay? Para mapataas yung blood volume. Para ma-normalize yung osmolality. Okay? So, although AVP contributes by minimizing renal water loss, thirst is the major defense against hyperosmolarity and hypernatremia. Okay? So, yung pagkauhaw daw, that is the major compensatory mechanism of the body against hyperosmolarity and hypernatremia. Okay? So, thirst ang pinaka-importanting defense mo against hyperosmolality and hypernatremia. Okay? Although hypernatremia rarely occurs in a person with a normal thirst mechanism and access to water, it becomes a concern in infants, unconscious patients, or anyone who is unable to either drink or ask for water. Okay? So, it happens to those, kasi if you are a healthy individual, with the thirst mechanism working properly, it will not develop or it will not lead to hyperosmolality and hypernatremia kasi your thirst mechanism is working properly. Diba? But unlike for babies wherein they cannot tell you yet kung nauuhaw ba sila, okay? So, they have a chance to develop hyperosmolarity. Aside from those, yung mga unconscious patient, yung mga na-coma, okay? Yung matagal na natutulog, or anyone who is unable to either drink or ask for water. So, osmotic stimulation of thirst progressively diminishes in people who are older than 60. Okay, nagde-diminish na yung compensatory mechanism nila ng pagkauhaw kapag tumatanda. Okay? So this one, response of the body to an increased osmolality of blood. Okay? So, we have to explain this. So, what happens if there is low blood volume or low blood pressure? Kasi kapag mababa yung blood volume mo, mababa din yung blood pressure. Okay? So, in hypovolemia or low blood volume, okay? So, again, that will stimulate thirst as a compensatory mechanism. So, your body will detect thirst, okay? And iinom ka. You will drink fluid. Aside from that, ADH is secreted. So, this one, the ABP or the antidiuretic hormone is secreted in the hypothalamus. And that will promote water retention. Okay, that is to increase the volume of water in the body. Aside from that, hypovolemia also decreases renal perfusion pressure. So in this case, what happens? Renin is secreted. Okay? So renin is secreted. And angiotensinogen will be converted to angiotensin 1. So the ACE that is found in the lungs will also convert the angiotensin 1 to angiotensin 2. So si angiotensin 2 will promote vasoconstriction. Okay? So promote vasoconstriction. Kasi nga, unang-una mababa pa yung volume ng blood. So, it will constrict the blood vessels. Okay? So, aside from that, si angiotensin 2, okay, will stimulate the adrenal gland to produce aldosterone. Okay? So, aldosterone will in turn promote potassium retention, but it also promotes sodium retention, but it also promotes potassium excretion. Okay? So, when aldosterone is secreted, maraming sodium ang nag-i-stay, pero maraming potassium yung umaalis. So, that happens when there is hypovolemia. Okay? How about if there is hypervolemia? Okay? High level of water is found in the blood. Okay? Or there is high blood volume. So, ANP, the atrial natriuretic peptide, is secreted. So, what is the mechanism or what is the effect of atrial natriuretic peptide secretion? Renal sodium and water is excreted. Anong nangyayari aside from that? Nagkakaroon ng vasodilation. Kasi nga mataas na yung blood pressure, maraming fluid sa system mo, maraming water, ano nangyayari? Tumataas yung blood pressure. So, anong gagawin ng katawan mo? Okay? So, i-excrete niya ang sodium and water para maging normal yung volume ng water sa katawan and idadilate niya yung blood vessel para ma-normalize yung blood pressure. Okay? How about in case of hyperosmolality and hypernatremia? Okay? So, in that case, kapag mataas yung level ng osmolality and mataas din yung level ng sodium, anong mangyayari? I-initiate yan ng thirst and ADH secretion so that water stays in the body. There is water retention. Kasi nga mataas na yung osmolality mo. Okay? Mataas din yung level ng sodium. Para ma-normalize yun, kailangan mo uminom ng maraming tubig. Kailangan mag-stay muna yung katawan yung water sa katawan para maging normal tong dalawa. Okay? So, I hope that this diagram is already clear to you. Madali lang naman siyang intindihin. Okay? So, there are 4 other factors that affect blood volume. First, that is atrial natriuretic peptide that is released in response to volume expansion. Kapag mataas yung volume, nare-release yung ANP para masecrete ang excess na water and sodium. Okay? So, this one also promotes sodium excretion in the kidney. Okay? Number 2, volume receptors independent of osmolality stimulate the release of ABP, which conserves water by renal reabsorption. So, if the body detects low blood volume, just like in hypovolemia, anong nangyayari here? DADH is secreted for water retention to happen. Okay? Another, glomerular filtration rate. So, it increases with volume expansion. So, si GFR, glomerular filtration rate, tumataas siya kapag mataas yung volume and bumababa si GFR kapag mababa yung volume. Okay? Blood volume. So, if everything are equal, okay, increased plasma sodium will increase urinary sodium excretion and vice versa. Pero kapag konti lang ang sodium mo, anong mangyayari? Mai-increase ang urine retention of sodium. Okay? So, we proceed with the electrolytes. Sodium. Okay. Sodium, that is the most abundant cation in the extracellular fluid. So, ito yung pinakamataas na cation sa plasma natin. Okay? Or even in other extracellular fluids. Sa may tissues, in between tissues, is sodium. Ang pinakamataas. 90% of all extracellular cations is sodium and largely determines the osmolality of the plasma. Okay, so it greatly affects the osmolality of the plasma. Sodium concentration in the ECF is much larger than the inside of cell. Okay, kabaliktaran siya ni potassium. Potassium is 20 times greater inside the cell than the outside. Okay. So, potassium, the major intracellular cation. Kanina, sodium extracellular. Major extracellular sa labas ng cell. Si potassium, major intracellular ion. Siya yung pinakamaraming cation sa loob mismo ng cell. So, like sodium, potassium would eventually diffuse across cell membrane until equilibrium is reached. So, there are 3 important processes for the regulation, okay, of sodium. Paano nare-regulate yung level ng sodium sa katawan? So, there are 3 important processes. First, that is intake of water in response to thirst. Second is the excretion of water. And third is the blood volume status. Okay, so again, hormones affecting sodium level. So, we're done with this one. Na-explain ko naman na to, di ba? Si aldosterone, pinapataas ng sodium. Atrial natriuretic peptide, pinapababa kasi it increases sodium excretion. Si aldosterone, it promotes sodium retention, kaya niya pinapataas. Clinical application. So, hyponatremia. What do you mean by hyponatremia? When the level of sodium is lower than the reference range. Okay? So, kapag mas mababa na siya sa 135 millimole per liter, that is clinically considered as hyponatremia. Okay? So, hyponatremia is one of the most common electrolyte disorder in hospitalized and non-hospitalized patients. Bakit guys sa hospitalized? Kasi diba, if you see, in hospitalized patients, they are constantly in IVF fluid. Yes, in IVF. Okay, constantly na nakaka-receive sila ng IVF, yung dextrose. Okay, so, imagine mo, sometimes that is in 1 liter, 900 ml. So, continuous yun na nai-inject sa katawan nila. So, in continuous din na may pumapasok na, aside from their water intake, meron pang pumapasok through their veins. Diba? So, levels below 130 millimole per liter are already considered as clinically significant. Okay? So, 135 up to something, yun yung reference range niya. So, kung bumaba na siya ng 130 millimole, importante na yun, clinically significant na siya. Okay? So, decreased levels may be caused by 3. Okay? 3 main factors, yung 3 main classification. Bakit bumababa yung sodium? Either because of increased sodium loss. Mataas yung nawawalang sodium sa katawan. Aside from that, increased water retention. Bakit bumababa ang sodium when there is an increased water retention? Because of the dilution that happens. Okay? Nade-dilute kasi siya because mataas yung blood volume. Okay? And in water imbalance. Okay? So, if you remember, sa hypoadrenalism, anong nangyayari? If you remember, paano nag-i-stay ang sodium? Okay? So, paano nag-i-stay ang sodium? Through the use of the adrenal gland. So, aldosterone promotes sodium retention. So, kapag nagkakaroon ng hypoadrenalism, okay, so the adrenal gland is not working properly. Therefore, it cannot secrete aldosterone, okay? So, or it can, okay, possible din naman na it can secrete aldosterone, pero at low level. So, kung hindi siya makapag-secrete ng aldosterone or mababa yung sinesecrete aldosterone, mababa din yung nag-i-stay. Okay? So, sodium retention is not promoted in that case. Aside from that, potassium deficiency. Bakit nagkakaroon ng increased sodium loss o potassium deficiency? Kasi the body needs uh, the body needs to take up potassium, okay? Or the body needs to what do you call this one? So the body needs to keep the potassium, okay? So if you remember, if sodium is excreted, potassium is excreted. Okay? If sodium stays in the body, potassium is excreted. Ganon din siya. If potassium stays in the body, ano mangyayari? Sodium is excreted. So, since there is potassium deficiency, if the body detects potassium deficiency, ano mangyayari sa potassium? Okay? So, ikikip niya yung potassium. Since kinip niya yung potassium, anong gagawin niya sa sodium? Itatapon niya yun. So, nagkakaroon ng increased sodium loss when there is potassium deficiency. Another, diuretic use. Okay? So, si diuretic, anong ginagawa ng diuretics? Okay? So, water is not kept in the body. Water is eliminated in diuretic use. So, masama doon si sodium, kaya nagkakaroon ng increased sodium loss. Okay, so for ketonuria, what happens in ketonuria is that sodium is excreted, okay, together with the ketones. So even sa salt-losing nephropathy, prolonged vomiting and diarrhea, and severe burns. Okay, later on guys, you will notice the prolonged vomiting and severe burns, they can also cause hypernatremia. Okay, weird no? So, si prolonged vomiting and burns, they can cause also hypernatremia. Okay? Sa increased water retention, renal failure, nephrotic syndrome, hepatic cirrhosis, congestive heart failure, and sa imbalance, kapag sobrang water intake, the syndrome of inappropriate arginine vasopressin hormone secretion, and as well as sa pseudohyponatremia. Okay? So, increased sodium loss in the urine can occur with decreased aldosterone production. So, na-explain ko na. So, here, kapag decrease ang aldosterone production, ano nangyayari? Hindi nag-i-stay, walang nangyayari na sodium retention. Therefore, sodium is excreted. Okay, in diuretics, so water is lost together with sodium, ketonuria, sodium loss with ketones, or salt-losing nephropathy with some renal tubular disorders. Okay, so potassium deficiency also causes sodium loss because of the inverse relationship. Okay, so when potassium levels are low, the tubules will conserve potassium, and at the expense of this conservation of potassium, sodium will be excreted. Kaya tumataas yung sodium loss, decreasing, leading to hyponatremia kapag mababa if there is hypokalemia. Okay, kasi i-correct ng katawan yung hypokalemia. Okay? So, each disorder, so this one, hypoadrenalism, potassium deficiency, diuretic use, ketonuria, so they result, okay, in an increased urine sodium level of greater than 20 millimole per, this should be DL, deciliter, which exceeds the amount of water loss. However, so ibig sabihin guys, itong mga naunang cause ng increased sodium loss, greater than 20 millimole yung madedetect mo sa urine. Pero sa prolonged vomiting and diarrhea as well as sa severe burns, ano nangyayari? Less than 20 millimole per DL. Is it D or DL? Guys, check nyo nga, baka mali pala ako ng sinasabi dito. Okay? So, check nyo na lang later. So, for prolonged vomiting and diarrhea as well as severe burns, ano nangyayari? The level of sodium in the urine is less than 20. Okay? Ma'am, bakit gano'n? Kasi nga, here, guys, yung mga unang cases, the sodium is lost through the urine. Kaya madedetect mo yung increased sodium sa urine. Pero sa vomiting and diarrhea as well as severe burns, okay? Urine kasi yung sample dito. So, paano ba sila nawala? Okay? So, this one sa burns, either nagkaroon ng fluid loss, okay? Fluid loss through the skin, and sa vomiting or diarrhea, nilabas mo yung sodium. Sa diarrhea, itinaim mo yung sodium. Kaya, hindi ganun tataas yung level ng sodium sa ihe. Okay, increased water retention causes dilution of serum plasma sodium as with acute or chronic renal failure. Okay, why guys in acute and chronic renal failure? Because the kidney cannot normally eliminate water. Hindi na siya nagpa-function properly. So, kung hindi siya nagpa-function properly, hindi na i-eliminate yung water correctly. So, ano nangyayari? Nag-i-stay yung water sa katawan leading to a hypervolemia that leads to dilution. Okay? In nephrotic syndrome and hepatic cirrhosis, plasma proteins also are decreased, resulting in a decreased coloid osmotic pressure in which intravascular fluid migrates to the tissue. Okay? So, nagkakaroon ng edema. The low plasma volume causes AVP to be produced, causing fluid retention and resulting in dilution of sodium. So, these compensatory mechanisms also seen sa congestive heart failure as a result of increased venous pressure. Okay? So, urine sodium levels can be used to differentiate the cause of increased water retention. Okay? Kagaya din ng to determine the cause of increased sodium loss. So, you can also use the urine sodium level. Where is that? So, urine sodium levels can be used to differentiate the cause of increased water retention. If that is greater than 20 millimole per D, it's actually D. Okay, hindi ko na ma-remember kung ano yung D. So, when urine sodium is greater than 20 millimole per D, acute or chronic renal failure is the likely cause. Okay, kapag mas mataas siya sa 20. Okay, pero kapag less than 20 siya, water retention may be a result of nephrotic syndrome or hepatic cirrhosis or congestive heart failure. Okay? So, water imbalance can occur as a result of excess water intake. As with polydipsia sa increased thirst. Okay? So, ano nangyayari? Nagkakaroon ng water imbalance. Kaya bumababa yung level ng sodium. So, the increased intake must be chronic before water imbalance occurs, which may cause mild or severe hyponatremia. Okay? In a normal individual, excess intake will not affect sodium levels. Okay? Because, bakit hindi? It will not lead to, where is that? So, in normal individual, excess intake will not affect sodium levels because walang problema sa katawan mo. So, if there is no problem, water is eliminated by the kidney. Okay? So, in the SIADH, okay, or in the syndrome of an inappropriate secretion, okay, secretion, I forgot. Let's check. Syndrome of inappropriate arginine vasopressin hormone secretion causes an increase in water retention. So, nagkakaroon din ng dilution because of increased AVP or the ADH production. Okay? Kaya nagkakaroon ng dilution. So, bumababa yung level ng hypo ng Sodium. So there are three categories of hyponatremia: low osmolality, normal osmolality, and high osmolality. Okay? Most instances of hyponatremia occur with low osmolality. Okay? So mababa yung concentration ng solutes. So this may be a result of sodium loss or water retention as previously mentioned. Okay, so we have here, so with low osmolality, these are caused by increased sodium loss and increased water retention. So pag mga with normal osmolality with hyponatremia, eto naman. Okay, yung mga hyper. Check nyo. Hyperkalemia, hypermagnesemia, hyperkalemia. Okay? Except for this one, sa pseudo-hyponatremia. Hyperlipidemia, hyperproteinemia. Okay? And the others. With high osmolality, it occurs in hyperglycemia and mannitol infusion. Kailan nangyayari yung hyperglycemia? Minsan sa diabetes mellitus. Okay, in pseudo-hyponatremia as mentioned, it may also be seen with in vitro hemolysis. Okay, consider the most common cause for false decrease. When red blood cell lies, sodium and potassium and water are released. So since the sodium concentration inside the cell is lower, it results to dilution. Okay, so it results to a false decrease. Meron namang sodium sa loob ng cell, tas lalabas, hindi ba tataas siya? No guys, bababa kasi there is also water present inside the cell. Okay? Yung water na nasa loob ng cell, lalabas din siya sa extracellular fluid. Okay? So, mataas, take note, mas maraming fluid sa loob ng cell compared sa outside. Diba 2/3 yun? So, ang mas mangyayari doon is dilution. Kaya siya bababa. Okay? Bababa yung level ng sodium in hemolysis. Pero kabaliktaran siya sa level ng potassium. Kapag nagka-hemolysis, tataas yung level ng potassium. Ma'am, bakit? Kasi nga, sobrang taas ng concentration ng potassium inside the cell. That is 20 times greater inside the cell compared sa outside. So, kahit lumabas ang water together with sodium and potassium, okay? So, kahit na-release yung water dun sa extracellular fluid, tataas pa rin yung potassium because of the high level. Okay? Sobrang dami yung lumabas. Kaya, tataas siya. Okay. So, symptoms depend on the serum level. If that is 125 to 130, symptoms involves gastrointestinal, okay, sa intestine. Pero kapag less than 125 na siya, dyan na lumalabas yung neuropsychiatric symptoms, kagaya ng nausea, vomiting, muscular weakness, headache, lethargy, and ataxia. Okay, so more severe symptoms also, seizure, coma, and respiratory depression. Okay, so a level below 120 millimole per liter for 48 hours or less, that is already an acute hyponatremia, and that is considered already as a medical emergency. So, kapag bumaba na siya ng 120 millimole per liter, okay, so, ano na yan? That is a medical emergency. That is already life-threatening. Kasi yung ibig sabihin ng medical emergency. Life-threatening. Okay? So, hypernatremia, increased serum sodium concentration. So, tumataas yung level ng sodium in these three cases. Loss of water relative to sodium loss. Mas maraming natatanggal or na-excrete na water compared sa na lumalabas na sodium. Okay? Decreased water intake, dehydration leads to hypernatremia. Or increased sodium intake or retention. Okay? Maraming nag-i-stay na sodium or marami kang nakakain na sodium. So, hypernatremia is less commonly seen in hospitalized patients than hyponatremia. Okay, why guys? Hindi ka din takalakain kapag na-hospital ka. Okay? Diba? So, hindi ka kumakain ng maigi. So, mas lesser yung chance mag-hypernatremia compared sa hypo. Kasi nga, because of the IV infusion. Okay? Loss of hypotonic fluid may occur either by the kidney or through profuse sweating, diarrhea, or severe burns. Okay? So, that's why that may lead to hypernatremia. If you remember, I already mentioned this one. Diarrhea and severe burns may cause either hyponatremia or hypernatremia. Hypernatremia may result from loss of water in diabetes insipidus. Okay? So, bakit tumataas yung sodium kapag may diabetes insipidus? Because of these two reasons. Okay? So, do not forget these two reasons on why there is hypernatremia when there is loss of water in diabetes insipidus. Because the kidney cannot respond to ABP. Okay? Kaya nagkakaroon ng hypernatremia. So, ibig sabihin, ang nangyayari dito, parang dehydration. Tumataas yung sodium kasi mababa yung volume ng water or mababa yung blood volume. Okay? Aside from that, because ABP secretion is impaired sa diabetes insipidus. Okay? So, yun yung reasons on why there is hypernatremia in diabetes insipidus. Diabetes insipidus that is characterized by a copious production of dilute urine. Okay? Ihi ng ihi. Hindi nagkakaroon ng water retention because of low ABP secretion or no ABP secretion. Okay, because people with diabetes insipidus drink large volumes of water. Bakit umiinom sila guys ng marami? Kasi nga there is constant thirst mechanism. Okay, laging nagsisignal yung katawan na okay, uminom ka, konti yung volume ng water sa katawan mo. Okay? Pero since walang nasa-secrete or sobrang konti yung nasa-secrete na ABP, hindi nagkakaroon ng retention. So, kahit inom sila ng inom, iniihi lang din nila ng iniihi. So, hypernatremia usually does not occur unless the thirst mechanism is also impaired. So, excess water loss may also occur in renal tubular disease, okay, in which the tubules become unable to fully concentrate the urine. So, they cannot concentrate the urine. Anong nangyayari? Na-excrete lang na-excrete ang water. So, with extrarenal fluid losses, the urine osmolality is increased. Interpretation of the urine osmolality in hypernatremia is also shown in Table 16-5. That should be dash. Water loss through the skin or by breathing accounts for about 1 liter of water loss per day in adults. So, imagine, yung pag-exhale mo pa lang, or even in talking, when you are talking, you are already exhaling a fluid portion of your body. Okay? So, any condition that increases water loss, kagaya ng fever, burns, diarrhea, or exposure to heat, will increase the likelihood of developing hypernatremia. Okay? So, even kapag yung mga causes ng dehydration, they lead to hypernatremia. Okay, so ito na yung classification related to urine osmolality. So, ito na, kasama na to sa lab part niya, guys. So, isama nyo to sa review nyo sa lab. So, symptoms of hypernatremia commonly involve the CNS as a result of the hyperosmolar state. Okay, so it commonly involves the CNS as a result of hyperosmolar state. It includes altered mental status, lethargy, irritability, restlessness, seizure, muscle twitching, hyperreflexes, fever, nausea, or vomiting, difficult respiration, and increased thirst. So, serum sodium of more than 160 per liter is associated with a mortality rate of 60 to 75%. Okay, so mataas din yung chance na mamatay ang isang tao na sobrang taas ng sodium niya. If that is more than 160, 60 to 75% yung chance na mamatay siya. Hypernatremia must be corrected gradually. Oh my gosh, sorry. Because too rapid a correction of serious hypernatremia can induce cerebral edema and death. So the maximal rate should be 0.5 millimole per liter per hour. So, what does this mean, guys? So, in hypernatremia, that must be corrected gradually. Pakonti-konti siya dapat na na-correct. Kasi kapag binigla mo, okay, if the correction is too rapid, pag binigla mo yung pagko-correct ng hypernatremia, that can induce cerebral edema and possible na mamatay ang patient. Okay, let's move to the major intracellular cation. Okay, yung pinaka-major na cation inside the cell. Okay, so that is 20 times greater inside the cell from the outside. So many cellular functions require that the body maintain a low ECF concentration of potassium ions. As a result, only 2% of the body's total potassium circulates in the plasma. Okay, so functions of potassium in the body include regulation of neuromuscular excitability, contraction of the heart, ICF volume, and hydrogen ion concentration. So if you check the function, guys, okay, that is important in neuromuscular excitability and contraction of the heart. That's why, okay, either there is hyperkalemia or hypokalemia that may lead to muscle weakness and cardiac arrhythmia. Mataas man o mababa yung level ng potassium mo, pwedeng mag-lead yan to muscle weakness or cardiac arrhythmia. Okay? So, this is very crucial, guys. Maintaining the level of potassium is very important because either tumaas yan or bumaba, pwede yung makapatay. Okay, pwedeng mamatay yung pasyente. Lower than normal difference increases cell excitability leading to muscle weakness. So, kapag mas mataas naman siya than the reference range, still, nagkakaroon ng cell excitability, so leading to muscle weakness. So, severe hyperkalemia, okay, mataas na level ng potassium, so can ultimately cause a lack of muscle. Okay, so, if the level of potassium is low, ano nangyayari? It increases cell excitability. Pero kapag mataas naman yung potassium level, ano nangyayari? Bumababa yung muscle excitability, which may lead to paralysis or fatal cardiac arrhythmia. Okay? So, hypokalemia decreases cell excitability, often resulting also to arrhythmia or paralysis. Okay? So, the heart may cease to contract in extreme cases of either hyperkalemia or hypokalemia. Okay? Kasi yun nga yung isa sa function niya, contractibility of the heart muscle. Potassium concentration also affects the hydrogen ion concentration in the blood. For example, in hypokalemia, kapag mababang potassium, as potassium is lost from the body, sodium and hydrogen move in the cell. Okay? So, if you try to imagine, kapag daw na-excrete or nawawala ang potassium, anong nangyayari sa sodium and hydrogen ion? Pumapasok sila sa loob ng cell. So, kapag pumapasok sila sa loob ng cell, si hydrogen ion is bumababa. So, in that case, they are decreasing the ECF, resulting to alkalosis. Okay? Kasi nga, si hydrogen ion concentration, it determines the pH. It can, kasi kapag mataas yung level niya, anong mangyayari? Acidosis. Pag bumaba yung level niya, anong mangyayari? Alkalosis. Okay? So, because this one is acidic. Okay? Kasi diba, if you remember, pH is the measure of hydrogen ion concentration. Kapag mataas ang hydrogen, ano nangyayari? Acidic siya. Pero kapag mababa, nagiging alkaline. So, kapag bumababa yung level ng hydrogen ion concentration sa plasma, kasi pumapasok siya sa loob ng cell, ano mangyayari? Alkalosis, nagiging alkaline. Regulation of potassium. Renal function related to tubular reabsorption and secretion is important in the regulation of potassium balance. So initially, the proximal tubules reabsorb nearly all of the potassium. Then under the influence of aldosterone, additional potassium is secreted in the urine in exchange of sodium. Okay, so thus the distal nephron is the principal determinant of urinary potassium excretion. So, most individuals consumes far more potassium than needed. Okay? Mas marami daw kinakain kaysa yung kailangan ng katawan. The excess is excreted sa urine but may accumulate to toxic levels if renal failure occurs. That's why guys, for person who have renal failure, okay, ang daming complications sa kanila. Kasi the body cannot do the compensatory mechanism that it needs to maintain electrolyte balance and normal plasma osmolality. Okay? Potassium uptake from the ECF into the cells is an important in normalizing an acute rise in plasma potassium concentration because of increased uptake. Anong ibig sabihin? Kakainin ng cell, okay? Yung pagkain ng cell sa potassium, that is a very important compensatory mechanism para mapababa yung potassium kapag madami kang kinain na food that is rich in potassium. Okay? Excess plasma potassium rapidly enters the cells to normalize plasma potassium level. As the cellular potassium gradually returns to the plasma, the potassium that was taken up by the cell, okay, so it is removed by urinary excretion. So 3 factors that influence the distribution of potassium between cells in ECF are as follows. Potassium loss, okay, frequently occurs whenever the sodium potassium ATP is inhibited, okay, in these conditions. So guys, take note, sa hypomagnesemia, anong nangyayari? Nagkakaroon din ng hypokalemia. Kapag mababa yung level ng magnesium, bumababa yung level ng potassium. Insulate promotes acute entry of potassium into skeletal muscle and liver by increasing sodium potassium ATPase activity. And catechol amines, kagaya ng epinephrine. So, they are important in the regulation of potassium. Si beta-2, so that is a stimulator. It promotes cellular entry. Okay, so anong ginagawa ni beta-2? So, it decreases the level of potassium sa blood. Guys, kasi ang pinag-uusapan natin dito yung level ng electrolytes sa blood natin, sa plasma. Okay? Yun yung sinasabi natin, tumataas or bumababa. Tumataas yung level ng potassium sa plasma, bumababa yung level ng potassium sa plasma or sa blood. Yun yung ibig sabihin nun, baka nalilito kasi kayo. Okay? So, for beta blocker naman, kapag beta blocker, so it blocks the cellular entry of potassium. So, anong nangyayari kapag may beta blocker? Tumataas yung level ng potassium sa blood kasi nga, hindi siya makapasok. Kasi merong nagpapablock ng kanyang pagpasok. Dietary deficiency or excess is really a primary cause of hypokalemia and hyperkalemia. So, exercise. Kapag nag-exercise, nakakataas ng potassium. Pero, bumabalik din naman siya after several minutes of rest. Okay, so this one, forearm exercise during venipuncture can erroneously result to high potassium concentration, high plasma potassium concentration. Kaya iniiwasan natin yung fist clenching, okay, yung pag-open and close ng hand because it increases potassium level. Okay? So, anong ginagawa niyo sa patient? You ask them to close their fist. Okay? But do not open and close it kasi nakakataas yun ng potassium level. Okay? So, in hyperosmolality, as with uncontrolled diabetes mellitus, causes water to diffuse from the cells carrying potassium with the water, which leads to gradual depletion of potassium if kidney function is normal. Okay, so ano ibig sabihin nun? Kapag nagkakaroon ng hyperosmolarity, normally, pumapasok ang fluid sa loob ng cell, okay, hyperosmolality as with uncontrolled diabetes mellitus causes water to diffuse from the cells. Okay? So, carrying potassium with the water. So, ano nangyayari? That leads to depletion of water kasi nga this occurs with devolution. Okay? Lumalabas yung water from the inside of the cell. Okay? Kasama ng plasma. So, bumababa pa rin yung potassium kasi nadidilute siya. Iba yung case ng hemolysis, guys. Kasi dito, konti lang naman yung lumalabas ng potassium. Okay? In cellular breakdown, so it releases potassium into the ECF. Wait. Okay, guys, going back. In cellular breakdown, so it releases potassium into the ECF. So examples are severe trauma, thrombolysis syndrome, and massive blood transfusion. In cellular breakdown, guys, ang nangyayari, tumataas yung level ng potassium. Okay? Tumataas yung level ng potassium. So, kapag sa kapag nagkakaroon ng lysis, okay, or cellular breakdown. So, hypokalemia is the plasma concentration below the lower limit of the reference range. Hypokalemia can occur with GI or urinary loss with potassium or increased cellular uptake. So, ano yung causes ng hypokalemia? Kapag nawawala siya, gastrointestinal loss, or pwede ring urinary loss, or pwede din naman kapag tumataas yung cellular uptake. Anong ibig sabihin ng cellular uptake? Tumataas yung pumapasok na level ng potassium inside the cell. So, common causes of hypokalemia are seen in table 16-7. Okay? Of these, therapy with thiazide-type diuretics is the most common. So, the use of thiazides or diuretics, where is that? The use of diuretics. Mahanap. Basta the use of diuretics, guys, is the major contributor to hypokalemia. So, this one pala, sa renal loss. Okay? So, GI loss, gastrointestinal loss, occurs when GI fluid is lost through vomiting, diarrhea, gastric suction, or discharge from intestinal fistula. Okay? So, those occurs in gastrointestinal loss of potassium leading to hypokalemia. So, hypokalemia, increased potassium loss in the stool, also occurs with certain tumors, malabsorption, cancer therapy, and even sa large doses ng laxatives. Okay? So, renal loss of potassium can result from kidney disorders such as potassium losing nephritis and renal tubular acidosis. In renal tubular acidosis, as tubular excretion of hydrogen ion decreases, potassium excretion also increases. Okay? So, because aldosterone promotes sodium retention and potassium loss, kapag nagkakaroon ng hyperaldosteronism, that leads to hypokalemia. Bakit it leads to hypokalemia? Kasi, sodium retention is promoted at the expense of potassium. So, maraming potassium yung naitatapon. Okay? Just because maraming sodium ang nag-i-stay sa katawan. Aside from that, metabolic alkalosis also happens. Bakit, guys? Because the hydrogen ion, cellular uptake of hydrogen ion is promoted. Kasi nga, nawawala to. Kapag this is excreted, cellular uptake of hydrogen ion is promoted, leading to alkalosis. Okay? So, hypomagnesemia can lead to hypokalemia by promoting urinary loss of potassium. So, do not forget, hypokalemia, okay, occurs also in hypomagnesemia. Okay? So, parang hypokalemia. Okay? So, mababa din yung, kapag mababa yung level ng magnesium in hypomagnesemia, okay, bumababa yun din yung level ng potassium. Kaya, nagkaka-hypokalemia. Renal potassium loss also occurs with acute myelogenous leukemia. Basta yung mga leukemia na yan, okay? Renal potassium loss happen. Okay, nawawala yung potassium through the kidney kapag may leukemia, kaya it leads to hypokalemia. Although reduced dietary intake of potassium rarely causes hypokalemia in healthy persons, decreased intake may intensify hypokalemia caused by the use of diuretics. So, increased cellular uptake of potassium. Okay, anong ibig sabihin nito? Tumataas yung pagkain ng cell ng potassium or tumataas yung level ng potassium na pumapasok inside the cell. So, this is encountered in alkalemia. Okay? And other reason is when insulin level is elevated in the therapeutics of diabetes. Okay? So, kapag nagkaka-hypokalemia kasi tumataas yung cellular uptake of potassium. Ibig sabihin, maraming potassium ang pumapasok sa loob ng cell. So, kahit sa mga diabetics, okay, bumababa yung level ng potassium kasi si potassium pumapasok siya sa loob ng cell. Okay? Sa mga diabetics na nagtitake ng insulin. Okay? So, insulin promotes the entry of potassium into the skeletal muscle and liver cells. Because insulin therapy can sometimes uncover an underlying hypokalemic state, plasma potassium should be monitored carefully whenever insulin is administered sa susceptible na pasyente. So, sa mga pasyente na nagtitake ng insulin, okay, dapat monitor din yung potassium level. Kasi pwedeng bumaba. So, a rare cause of hypokalemia is associated with a blood sample. So, in a patient with leukemia, okay, di ba pag leukemia mataas kasi yung level ng white blood cell. Kapag in-stand mo yan, hinayaan mo mag-stay muna doon yung blood, magkakaroon ng pseudo-hypokalemia kasi kakainin ng cells yung potassium. Kaya yung ibig sabihin nun. Symptoms ng hypokalemia, weakness, fatigue, constipation, often become apparent as plasma potassium level decreases below 3 millimole per liter. Ang reference range kasi nito is 3.5 to 5 millimole per liter. So, di ba, 0.5 lang yung decrease niya, pero meron ng mga symptoms. Hypokalemia can lead to muscle weakness or paralysis, which can interfere with breathing. The dangers of hypokalemia concern all patients, but especially those with cardiovascular disorders because of an increased risk of arrhythmia, which may cause sudden death in certain patients. Hyperkalemia, kakapagod. Okay, patients with hyperkalemia often have an underlying disorder. Sa hyperkalemia naman, greater than the upper limit of the normal range. Okay, so for patients with underlying disorder, kagaya ng may mga renal insufficiency, diabetes mellitus, metabolic acidosis, so those contributes to the development of hyperkalemia. So the most common cause of hyperkalemia in hospitalized patients is due to therapeutic potassium administration. So the risk is greatest with IV K replacement. So normal cellular processes gradually release excess potassium back into the plasma, where it is normally removed by renal excretion. Impairment of urinary potassium excretion is usually associated with chronic hyperkalemia. So if the body cannot remove excess potassium in the blood, ano mangyayari? It will lead to hyperkalemia. Okay? Kagaya na lang sa cases wherein there is impairment of urinary potassium excretion. Okay? So, if a shift of potassium from cells into plasma occurs too rapidly to be removed by renal excretion, acute hyperkalemia develops. So, in diabetes mellitus, insulin deficiency promotes cellular loss of potassium. Okay? So, hyperglycemia also contributes by producing a hyperosmolar plasma that pulls water and potassium from cells, promoting further loss of potassium into the plasma. In metabolic acidosis, as excess hydrogen ion moves intracellularly to be vaporized, potassium leaves the cells to maintain. Okay? So, sa acidosis kasi, metabolic acidosis, anong meron? Mataas yung level ng hydrogen ion sa labas. Okay? Sa extracellular, sa fluid, sa plasma. So, ano yung compensatory mechanism ng katawan? Dapat si hydrogen ion concentration, papasok siya inside. Okay? Para ma-normalize yung pH ng blood. So, if hydrogen ion concentration moves intracellularly, okay, para maging normal yung pH, kapalit niya yung potassium. So, as hydrogen ion enters the cell, potassium is excreted from the cell, okay, or potassium is lost inside the cell, or lumalabas si potassium, kaya nagkakaroon ng increased potassium in metabolic acidosis. Kasi nga dun sa compensatory mechanism niya. In metabolic acidosis, mataas yung hydrogen ion concentration. So, ang gagawin ng katawan is to move the excess hydrogen ion inside the cell. So, in that case, si potassium naman yung lalabas para ma-maintain yung electroneutrality. Okay? Because cellular potassium often becomes depleted in cases of acidosis with hyperkalemia, okay, kagaya din sa diabetic ketoacidosis, treatment with agents such as insulin and bicarbonate can cause a rapid intracellular movement of potassium, okay, producing severe hypokalemia. Okay, so, in cases ng diabetic ketoacidosis, okay, ano nangyayari? Nagkakaroon ng hyperkalemia. Even sa acidosis, di ba? Metabolic acidosis or diabetic ketoacidosis, nagkakaroon ng hyperkalemia kasi nga lumalabas yung potassium. So, kailangan mo ding i-correct yun kasi hindi rin maganda na mababa yung level ng potassium sa loob ng cell. So, in that case, those are sometimes treated with insulin and bicarbonate. Okay? However, ang drawback pa rin yan, that may also produce severe hypokalemia. Kasi baka mostly naman ng potassium na nasa extracellular fluid is pumasok sa loob ng cell. Yun yung ibig sabihin nun. Hyperkalemia may result when potassium is released into the ECF during enhanced tissue breakdown or catabolism, especially if renal insufficiency is present. So, kapag nagkakaroon ng catabolism, o nagkakaroon ng necrosis, tissue destruction, hemolysis, nare-release yung potassium sa extracellular fluid. Take note guys, si plasma extracellular fluid yun ha. Kasi nasa labas siya ng cell, baka hindi tayo nagkakaintindihan. Okay? So, tumataas ngayon yung level ng potassium. Okay? Lalong-lalo na daw sa mga taong may renal insufficiency. Okay? Kasi, in normal individual, kapag sinasabi natin normal dito guys, wala siyang sakit. Kapag walang sakit yung tao, kahit tumaas yung level ng potassium sa blood niya, may excrete yun through the urine. Pero kapag there is renal insufficiency, hindi kaya ng katawan niya na ilabas yung sobrang potassium. Kasi nga, the kidneys not functioning properly. Okay? Increased cellular breakdown may be caused by trauma, administration of cytotoxic agent, massive hemolysis, tumor lysis syndrome, and blood transfusion. So, in bulk blood, potassium is gradually released from the erythrocyte during storage, often causing elevated potassium concentration dun sa plasma supernatant. So, patients on cardiac bypass may develop mild elevation in plasma potassium during warming after surgery because warming causes cellular release of potassium. Pero kapag yung temperature naman is mababa, kagaya sa hypothermia, anong nangyayari? Yung potassium movement papunta sa loob ng cell or potassium movement going inside the cell happens. Okay? So, ano daw nangyayari sa blood that is stored, donated blood that is stored, the potassium is gradually released sa erythrocyte. Kaya tumataas yung potassium sa plasma level ng mga donated na blood. So, these are the causes of hyperkalemia. So, guys, yung reference ko dito is si Bishop. I believe you have Bishop naman. So, kung may mga hindi kayo naintindihan sa sinabi ni Ma'am, okay, may hindi kayo naintindihan sa explanation ni Ma'am, you can refer to Bishop. So, these are the causes of hyperkalemia. Guys, ulit-ulitin nyo lang pakinggan yung recording or ulit-ulitin yung basahin yung discussion ni Bishop. Kapag una kasing encounter mo, mahirap siyang intindihin. Ganun naman talaga pag unang encounter. But the more that you repeat the lesson or the more that you repeat reading something, the more that you will understand it. Okay? Hyperkalemia can cause muscle weakness, tingling, numbness, or mental confusion by altering neuromuscular conduction. Muscle weakness does not usually develop until plasma potassium reaches 8 millimole per liter. So, symptoms of hyperkalemia, so it disturbs cardiac conduction, which can lead also to cardiac arrhythmia and cardiac arrest. So, parang pareho kasi sila ni hypokalemia. Okay, may cardiac arrhythmia na nangyayari. Either mataas or mababa. Plasma potassium concentrations of 6 to 7 millimole may alter the ECG, and concentrations more than 10 millimole per liter may cause fatal cardiac arrest. So that ends, guys, the first part of our discussion on electrolytes. Thank you for listening.